sorry, what I'm not going to do is talk about rectal cancer. That is a really big topic, and I could do a two-part lecture on rectal cancer. It's so big, so I'm just focusing on colon cancer in this discussion. And so I think whenever I see a person in the clinic, I always ask them what they came in for and if they know what their diagnosis is and why they're here there to see me. Because I feel like a lot of times I get this response. My surgeon got it all. And so some of them will say, and he sent me here to talk to you about chemotherapy. And a lot of times people will say, oh, I don't know why they're sending me here. My surgeon said they got it all. And that's really tough. So I hate that statement. I think it's maybe it's appropriate for stage 1 or low risk stage 2 patients, but otherwise it sets inappropriate expectations for the patient. Instead, what I have asked them to do is say that I got all the visible disease. Now I'm sending you to Dr. Breakstone to talk about what to do with any invisible disease if there is any. And that's what I tell my patients, that the purpose of adjuvant chemotherapy is to manage any occult micrometastatic disease. So as far as we know, they're in remission, but the findings on their postoperative pathology raise the concern for, hidden disease, and that's what we're treating. And so there's a lot of with increasing time, there's actually been more controversies with adjuvant treatment in colon cancer, specifically, who needs adjuvant colon cancer? What I think is at play currently is, so high risk stage 2, all stage 3 patients should receive or at least be considered for adjuvant chemotherapy, and then stage 4 with resected oligometastatic disease, and then, ctDNA positive patients. And then, what's the regimen of choice? It's FOLFOX or CAPOX. There hasn't really been any data to support adding anything to this regimen. And I'm talking about microsatellite stable patients in this case. And then duration of treatment, 3 months versus 6 months. And we'll get into that throughout this discussion. And so in talking about general principles of adjuvant therapy, hopefully you guys know this information and this is just a review, but postoperative 5-FU-based chemotherapy is still universally recommended for all patients with stage 3 or node-positive colon cancer. The benefit of adding oxaliplatin to 5-FU or capecitabine has clearly been demonstrated in the stage 3 population in 3 landmark prospective trials. The MOSAIC trial, which was 5-FU leucovorin versus FOLFOX in resected stage 2 and stage 3 cancer, the NSA-BBC 07 trial, and the Zaloxa trial both demonstrated the equivalence of capecitabine to FOLFOX in the adjuvant setting. That said, the benefits of adjuvant chemotherapy for stage 2 colon cancer remains controversial. All the national recommendations in this country recommend at least 5-FU in consideration for FOLFOX in patients with high-risk stage 2 colon cancer, but there really is no good data that demonstrates consistent statistical significant improvement in disease-free survival or overall survival in stage 2 colon cancer. Those recommendations are based on a non-significant trend in that high-risk population noted in the MOSAIC trial. And then again, no studies have benefited adjuvant use of irinotecan or targeted agents such as bevacizumab or EGFR inhibitors like cetuximab or panitumumab. So to address the question of the optimal duration of treatment, 3 versus 6 months. It was 6 months forever until 2018 when the IDEA trial was initially published. This was a six concurrently conducted phase 3 trials The Tosca trial was Italy, the Scott trial was in Northern Europe, IDEA was in France, Achieve was in Japan, HORG was in Greece, and the CALGB SWOG 80702 was the US counterpart. This was a prospective, pre-planned pooled analysis of 6 separate randomized phase 3 trials to evaluate a non-inferiority of adjuvant therapy with either FOLFOX or CAPOX administered for 3 versus 6 months. And what was initially published in 2018 was the disease-free survival benefit, and what this demonstrated is that with the available 3-year disease-free survival data across these studies, across the populations, the statistical non-inferiority of 3 months of treatment was not confirmed. However, there has been a lot of debates over the clinical interpretation of these results, considering the huge reduction in toxicity. And we're not talking about just, neurologic toxicity from neuropathy, but like financial toxicity, time off from work.
He's going to head right in.
3 months versus 6 months makes a huge difference. And so again, the primary endpoint was actually disease-free survival at 3 years, and then non-inferiority was claimed if the upper limit of the 95% confidence interval did not exceed 1.12, and it did in the overall population. It didn't in the overall population, and overall. 40% of patients received CAPOX, but this was exclusively in the UK and Japan. And in the CALGB SWOG trial conducted in the US, all of those patients which received FOLFOX. So 60% of those patients received FOLFOX, and all US patients received FOLFOX. And then what the results, again, in the overall study population, non-inferiority was not met, but there was non-inferiority seen for CAPOX, but not for FOLFOX across, when specified by regimen. And then when stratified by risk group, disease-free survival, there was non-inferiority of the shorter regimen for both FOLFOX and CAPOX in the low-risk group, but not in the high-risk group. And, low risk group was T1 to 3, and 1, and then high risk was N2 or T4 malignancy. So in the overall survival data that was later published, again, non-inferiority was not met in the overall population, and so it failed to reject the null hypothesis. But when you look at the survival, 5-year overall survival by regimen, in the CAPOX groups, it was considered, it did meet non-inferiority. And in the FOLFOX groups, non-inferiority was not met. Again, this is just based on regimen. And then when you stratified them by risk group, in the low risk group, again, they met non-inferiority, and in the high risk group, non-inferiority was not met. When you look at all 4, subgroups, they essentially, if you have low risk and treated with FOLFOX, 3 months is okay. If you have high risk FOLFOX, then that is clearly a relevant loss of improvement, and those people should not be treated with 3 months of FOLFOX. They should be treated. If you're going to give FOLFOX, you should give 6 months in high-risk patients. Then in low risk and in the high risk, essentially CAPOX was okay. And so the summary is that it definitely verified there are lower rates of grade 2 toxicity with 3 versus 6 months of oxaliplatin, 14 versus 46%. The primary 3-year disease-free survival and the 2 secondary endpoints, which were 5-year overall survival and disease-free survival, showed minimal difference in the low-risk majority. So 60% of patients were low risk with 3 months of adjuvant therapy. though the trial was not randomized for regimen, the drug regimen effect was actually observed in every endpoint and confirmed with longer follow-up. So no loss of efficacy observed in low-risk patients with 3 months of CAPOX. There's minimal loss with 3 months of CAPOX in high risk, and 3 months of FOLFOX in low risk, but a relevant loss with 3 months of FOLFOX in high risk. So in terms of how this affects clinical practice, stage 3 can be stratified to high versus low risk. Even though the overall population didn't really meet non-inferiority, the survival difference was actually relatively small. We're talking 4 to 5%. In those patients with low-risk disease, 3 months of adjuvant therapy is adequate, preferably with CAPOX, though you can consider FOLFOX if you anticipate poor tolerance or access to capecitabine. You have to keep in mind that no Americans received CAPOX, and the American population is well known to have inferior tolerance to capecitabine, and that in those high-risk patients, for the majority, the risk-benefit assessment does suggest that 3 months of CAPOX is feasible as well. For those unwilling to lose even 1 to 2% of efficacy, then 6 months of therapy is recommended. So in terms of what I do, if I think a person can tolerate it and they have low-risk disease, I try for 3 months of CAPOX. If they can't tolerate the capecitabine, then I have a relatively low threshold to switch them to FOLFOX. But if I think they can tolerate it, I at least try the CAPOX. And then in my patients with T4 or N2 disease, I almost all universally give those people 6 months of FOLFOX. The reason being is that for the American the patients who saw that benefit to CAPOX were not in the American population. The doses of CAPOX that they got were 1,000 to 1,200 milligrams per meter squared, which is not a tolerable dose range for the American population. So I'm not really sure that non-inferiority at 6 months with CAPOX rings true for Americans. And patients can tolerate 3 months of FOLFOX, but once you start getting past 3 months, they have diminishing tolerance to CAPOX. So for the most part, if I'm going to give 6 months of treatment, it's going to be with FOLFOX. And then just, comparing those regimens, CAPOX is a 21-day regimen, FOLFOX is a 14-day regimen. The dose of capecitabine is anywhere between 850 to 1,000 milligrams per meter squared twice a day, day 1 through 14. I guess, I would say if the standard dose is 1,000 milligrams, and then, some people suggest that 850 is more tolerable for the American population. Again, I start with 1,000, but I'm very frequently dose adjusting along the way. And the dose of oxaliplatin is 130 milligrams per meter squared, and then FOLFOX is 400 milligrams per meter. Oh, it's not cubed, but squared bolus, and then 2,400 meter squared over 46 hours, day 1 to day 3. Leucovorin, bolus, oxaliplatin, 85 milligrams per meter squared, and then just some pearls. Capecitabine is renally cleared, so it's contraindicated if your creatinine clearance is less than 30. There is definitely increased GI toxicity associated with the capecitabine relative to infusional 5-FU. There are more mouth sores, diarrhea, nausea, and it seems to get worse with each cycle. Many people don't experience those GI toxicities of capecitabine until day 10 to day 14 or beyond. So the last few days of the capecitabine course and in the 3 to 5 days after completion. So that's something to keep in mind in terms of following patients. I follow most patients on CAPOX weekly for the first cycle just to see how they tolerate it, because some people can actually develop quite significant mucositis and diarrhea, even if they are DPD proficient. And then, just some things to keep in mind for FOLFOX. There's no benefit of adding oxaliplatin in elderly patients by data, but I think that data might be a little bit out of date, since it was based on the Mosaic trial that was published in the 1990s. I think the elderly people are living healthier and living better. And if I'm giving 3 months of chemotherapy, I will, in an elderly patient, I will do FOLFOX. I'm not doing 5-FU, 3 months of 5-FU. Bolus 5-FU has a higher risk of GI toxicities, and so I never give it to elderly patients because of that. So anyone over the age of 70 and even over the age of 65, I sometimes consider holding the 5-FU bolus. There is phase 2 data showing that it doesn't really you're not really compromising efficacy by holding the 5-FU bolus. Though the bolus 5-FU has a higher risk of GI toxicity, it has a lower risk of cardiac toxicity. So in patients who have 5-FU cardiac vasospasm, there is data that giving a bolus regimen instead of the infusional 5-FU can be safely done without cardiac toxicity, of course with close monitoring, but that is a scenario where you might allow for the risk, the benefits of bolus 5-FU might outweigh those toxicities. And oxaliplatin infusion reactions can be managed by slowing the infusion for 3 to 4 hours and increase the pre-meds. Any questions so far? So I'm going to briefly go through this clinical vignette. So this is a patient I recently saw, 61-year-old, had a history of left breast cancer. Even though he actually is not BRCA, he was tested twice. ER/PR positive. He had a lumpectomy in August of 2012, and then adjuvant chemotherapy, and then completed tamoxifen. He has chronic neuropathy after Taxol with pins and needles of his feet, from his toes to the balls of his feet. And though it doesn't interfere with driving or balance or recurrent falls, when he stands for a long time or walks, it's increasingly uncomfortable, and usually he has to rest off his feet. He had a positive Cologuard on March 2024, but he lost insurance and he didn't get a colonoscopy until a year later, and they saw this fungating, ulcerated, partially obstructed large mass in the proximal transverse colon with oozing. His CAT scan was without metastatic disease, though, question of the prominent adjacent lymph nodes, and he had a right hemicolectomy. So post-operative path showed this tumor in his hepatic flexure, so right-sided, moderately differentiated, invading the paracolic tissues with focal mucinous features. So T3, 8 tumor deposits, 3 out of 26 lymph nodes with metastatic cancer, no LVI, PNI, margins negative, and he's microsatellite stable. Anyone want to suggest a adjuvant regimen for this patient?
I think I would do 5-FU monotherapy. I think if he's got bad neuropathy, maybe the oxaliplatin is not feasible, and we know there's no benefit to adding the irinotecan.
Okay. Anyone else? So this is a high-risk guy. I mean, he has got mucinous features are a high-risk feature, 8 tumor deposits. Tumor deposits are essentially satellite lesions, and they are considered a lymph node equivalent. So his stage is T3 and 1B. So he would fall technically under a low-risk group, but he has other features that are concerning for occult metastatic disease, like 8 tumor deposits. There are some publications that suggest that you can add tumor deposits to your lymph nodes, in which case he would be N2. So I think he's pretty high risk for recurrence. And so I talked to him about 6 months of FOLFOX. The reason I was okay with FOLFOX is because even though he has residual neuropathy, I think that he would benefit from the addition of oxaliplatin, and we can watch him closely for any worsening. It doesn't interfere with driving, so it's only limited to the balls of his feet to his toes, and so I I talked to him about adjuvant FOLFOX, and then his ctDNA testing did return positive actually yesterday, and so that will segue into our next topic, which is what do we do with ctDNA? And so there have been many studies with how ctDNA affects prognosis and how we can, potentially use it to our benefit in terms of guiding therapy, both in the metastatic and in the adjuvant setting, but primarily in the adjuvant setting. I would say without exception, all of these trials have identified ctDNA positivity as the highest risk factor for recurrence after an R0 surgery. ctDNA positive patients 4 weeks post-op, again, all of these studies have demonstrated that they have a shorter disease-free survival and an overall survival. And in fact, most of them relapse within 1 to 2 years of their surgery. That ctDNA turns positive more frequently than CEA prior to recurrence on imaging. So there is often a lag between ctDNA positivity and radiographic recurrence. So all of these studies have demonstrated that, and I'll go through the studies in a couple of slides. The goal of use and the study for ctDNA is really to figure out how to utilize ctDNA to personalize treatment in adjuvant colorectal cancer in a way that doesn't compromise outcomes. So the current study is focused on either de-escalation or escalation of treatment based on ctDNA. Can we de-escalate or hold chemotherapy in patients who are ctDNA negative safely? So, and this is mostly in the stage 2 population that's relevant. And does escalating adjuvant therapy in the highest risk population, those who are ctDNA positive, help? And what is the best strategy? So this is especially pertinent because the risk prediction for stage 3 colon cancer needs improvement. The optimal management of stage 2 colon cancer continues to be debated. Even in the Mosaic study, which again kind of set the standard, even in the high risk stage 2 population, the absolute benefit of adjuvant chemotherapy is on the order of 5%. So that is not that much of a benefit. In stage 3, it's on the order of 25%. So that I would say that the benefits of that increase, justifies the risk. So how do we maximize benefit and avoid overtreatment when surgery cures over 75% across the population? And then, what has been consistently noted, again, is that post-op ctDNA MRD detection is highly prognostic. So could a ctDNA-informed approach to adjuvant therapy selection in stage 2 colon cancer and even stage 3 colon cancer reduce chemotherapy use without compromising survival outcomes? There are a lot of different ctDNA assays out there for MRD and also for assessing, for tumor-specific mutations or genetic alterations. There are tumor-informed assays where a specimen from the patient's tumor is required for evaluation. Typically, they extract, or at least with Signatera, they extract a panel of genes that are unique to the tumor and not present in the normal circulating free DNA. And use that as a panel for each individual to kind of screen for ctDNA in the peripheral blood. So that is those assays include Signatera, which of these 3 is the only one that's commercially available for use. The PGDX is a research assay, and the SAFE-Seq-S is also a research assay through Johns Hopkins, but it has been used in some of these studies that we're going to assess. The downside is that the turnaround takes about 4 to 6 weeks, 3 weeks from the receipt of the tumor at the company, and so that is not as beneficial, especially if you're trying to make decisions in terms of adjuvant therapy. And then tissue agnostic includes Guardant Reveal and Guardant Lunar. Guardant Reveal is the MRD assay for surveillance. Guardant Lunar is actually now being marketed for screening, so in lieu of colonoscopy, so that is out there. And the turnaround typically is about 7 to 10 days. So you have a better turnaround, though arguably specificity might be a little bit lower with agnostic versus tumor-informed, and there are certain scenarios where you might want a tumor-informed over tumor-agnostic, like if you have a patient who has more than one cancer and you're trying to assess for their colon cancer and not anything else.
So do we have Signatera available at Rhode Island Hospital?
Oh yeah, since 2020, I've been using it very regularly.
Okay.
You just need to get the kits. The kits are actually in our with the GI navigators, and it is being used more frequently by other providers. So you just need to get the kit, put the order on the portal, just like Guardant.
Okay, cool. Thank you.
So these are a list of the trials that have been done and reported. Most of these trials are observational trials, and then the last two are interventional trials. So the BNT 000-001 is one of the longest running epidemiologic studies, and it's been conducted through BioNTech in USA, Germany, Belgium, Spain, and it uses the adjuvant population, so stage 2 high risk and stage 3 patients. Their most recent results were presented in abstract in form in ASCO 2024. At that point, they had evaluated 852 patients, and of patients who were stage 2 high risk and stage 3, 13% of them were ctDNA positive 4 weeks post-op. And they noted that, again, highly prognostic, disease-free survival 1 year after surgery, so pretty soon after surgery, was 47.2% versus 93%. So in that ctDNA population, almost half of them had recurred within 12 months after surgery. Then there was there's the bespoke trial, which was just in the U.S. using a tissue-informed assay, Signatera. These were stage 2 and stage 3, so this included low-risk stage 2. And they had 689 patients, again observational. These patients had ctDNA pre-op, so these were deemed stage 2 to 3 resectable based on preoperative imaging and assessment. They got the ctDNA immediately pre-op, and then 4 weeks post-op, and then followed on a surveillance schedule. And what this study showed us is that in again the stage 2 general population, not just high risk, but all stage 2 patients, about 6% of those patients were ctDNA positive. In the stage 3 population, not surprisingly, they have a higher risk for recurrence. That was the risk increased to 22%. And when they assessed 2-year disease-free survival, 91% who were MRD negative versus a third that were MRD positive were disease-free at 2 years. And this study, importantly, noted a benefit from adjuvant chemotherapy in that MRD positive group with a hazard ratio of 3.06, and which was statistically significant, but not in the MRD negative group. But again, there was a lot of patients that wouldn't have even been considered for chemotherapy in that population with stage 2 patients. Importantly, you can note that in stage 2 cancer, 93% of those patients were MRD Oh, you know what? Sorry, I'm thinking of something else. Anyway, and then so the Circulate Japan is a huge study, and it is the largest one to date, the largest observational study to date. This is the Galaxy. A portion of it was the observational portion. They do have 2 interventional arms, which we'll talk about down in future slides. They also use Signatera, so tissue informed. They assessed stage 1 to stage 4 patients who had an R0 resection and had accrued 2,058 patients to this trial. And they checked ctDNA after resection at 4 weeks and 12 weeks. And what they found, again, similar to Bespoke, 2-year disease-free survival was 94% versus 34% in ctDNA positive patients. In stage 3 patients who were ctDNA positive, that was 26%. And if you look at the ctDNA group between high risk stage 2 and stage 3, there is a difference. 94% in stage 2 did not recur in 2 years, but only 8. That number dropped to 86%, which kind of suggests this possible false negative window in this higher risk population. And so there are 2 populations that we know have less sensitivity for ctDNA detection at recurrence. Does anyone know where that is? Like where they recur, where you might not detect it?
I mean, I would guess CNS disease, but that's probably pretty rare in colorectal.
Yeah, CNS disease, peritoneal disease. So you can have pretty extensive peritoneal disease and not shed ctDNA into the circulation if it's limited to the peritoneum. So that is especially important for patients who have T4 disease and are therefore at risk for peritoneal disease. And I'll tell you, I had a patient with widespread peritoneal mets that I was following with Signatera, and she remained Signatera negative and had like a large volume of peritoneal recurrence. No other visceral mets, but so I can tell you from experience it happens. And also in the lung, there's actually a lower shedding when you have lung mets. Did someone have a question?
Yeah, I was just wondering, is there like a role for like peritoneal lavage or something and send that out?
No, I mean, not in the absence of, because how would you follow those patients? Do peritoneal lavage serially? Presumably, when they had their tumor removed, they didn't have any visible, peritoneal metastatic disease at the time if they were considered R0 at resection.
If the Garden 360, like if someone had a Garden SAM, then it's positive. Is it better to follow with that? Because that, at least from when I see reports from Signatera, it's kind of like positive, negative, or but the Garden gives you more like mutations and percentages and things like that. Is that correct?
But if you don't have ctDNA shedding into the circulation, neither Guardant nor Signatera is going to detect that. And I've actually had false positives with Guardant because, people can have mutations in their CF DNA that are not related to their tumor, but are, considered oncogenic, so I can think of 2 patients that were positive on Guardant that were negative on Signatera and was like a false positive. That number is considered very low in all of the Guardant data, but there is a role for more. It is a broader. It is not as specific as tissue informed approaches using the. It's maybe perhaps more sensitive in some ways, but otherwise, not in that scenario. If you don't have ctDNA shedding. And then track B was using Guardant Reveal. That was done in the UK with stage 1 to 3 colon cancer patients. Again, similar. This study demonstrated that the ctDNA negative did much better than ctDNA positive patients. And this study also specifically highlighted that median time from ctDNA detection to radiographic recurrence was up to 7.3 months. So then there's our 2 interventional trials that have data, and that's COBRA and Dynamic 2. So COBRA used Guardant Lunar, so tissue agnostic. It was done in the US. The patient population was stage 2 colon cancer without high-risk features, and they accrued 635 patients. So these are patients who would otherwise be followed on observation. This is not an adjuvant. So they're trying to capture this in low-risk patients, finding those few patients that recur. We're talking about less than 2% in stage 2 colon cancer with high-risk features. And so this was a phase 2, phase 3 randomized controlled trial. They randomized, so it was 2 to 1. So 2/3 of the patients were evaluated in a ctDNA informed approach versus standard of care observation. So all of those people had standard of care, which is observation, right? If you have stage 2 colon cancer without high-risk features, standard of care is observation. And then in the ctDNA informed group, if you were ctDNA positive, then you received standard of care FOLFOX or CAPOX for 3 to 6 months, whatever that was that was physician's choice. The primary endpoint was ctDNA clearance if they were ctDNA positive, which has also been established in these observational trials, that if you have ctDNA clearance, you have a better 5-year disease-free survival. So this closed early after failing to meet that primary endpoint analysis. ctDNA clearance after 6 months was 43% in control. So we're talking patients who were followed on observation versus 11% in the experimental arm. So in this low-risk population, there doesn't seem to be a benefit in a ctDNA-informed approach. And so this tells you that you can also have false positives, right? Why else would you clear your ctDNA within 6 months if you were on observation alone? So there are both false positives and false negatives. The false positives might increase when you are approaching a lower and lower risk population. Dynamic 2 was conducted in Australia and New Zealand. They used SafeSeq, which is a tumor-informed research ctDNA assay, and they looked at all stage 2 patients, so high risk and low risk. It was just stage 2, and then they were randomized to either path-informed, which was considered standard of care, or ctDNA informed. So if they were in the ctDNA informed group, if they were positive, they all received chemotherapy. And what they found was that the 5 years relapse-free survival with and in 5-year overall survival, the ctDNA informed and the standard of care both did well, with no statistically significant difference between the 2 arms. And so I'm going to go through that trial because that was one of the first, this is the first interventional arm in the adjuvant population that has data that's been published. This was published in New England Journal of Medicine shortly after it was presented at ASCO 2024. So this was again in resected stage 2 colon cancers, randomized to receive adjuvant treatment based on standard clinical and histopathologic criteria, or ctDNA, guided by ctDNA positivity. It was in Australia and New Zealand. And primary endpoint was relapse-free survival at 2 years, and then secondary endpoints include the proportion who received adjuvant chemo, overall survival, ctDNA status, end of treatment, ctDNA clearance. And what they found is that when they used a ctDNA guided approach, it reduced the use of adjuvant chemotherapy without statistically significant difference in 5-year relapse-free survival. That those who had ctDNA clearance Number one, that it was achieved in a high percentage of patients who received adjuvant treatment. So in 87.5% of ctDNA positive patients 4 weeks post-op who received adjuvant chemotherapy, they cleared their ctDNA. And that ctDNA clearance was associated with a favorable outcome compared to those patients without ctDNA clearance, to 85% versus 20% if they had persistent ctDNA detection. And they further highlighted this ctDNA approach by showing that there were really good survival rates of 90.6% in untreated ctDNA negative T4 tumors, which is a population where you might have false positives. And when you look at the stage 2 colon cancer cohort in general, the two highest risk factors, there's there are several risk factors that impart quote unquote high risk. T4, LVI, PNI, poorly differentiated, presenting with obstruction. Consistently, T4 and LVI have been the two risk factors that carry the most weight in terms of high risk features and recurrence. So in this the highest risk histopathologic criteria in this ctDNA import, the study authors purport that they retained this 5-year overall survival rate of 90.6%. So looking at baseline characteristics, they were pretty matched. It is important to note, though, that in this patient population, the majority of patients were low risk, right? So we're talking about patients who would otherwise have had observation. Only 40% of patients in both ctDNA guided and standard management had would have been otherwise recommended to receive adjuvant chemotherapy. And when they looked at those patients who were post-op, had post-op ctDNA positivity, it did correlate with what we know, what we use as those clinical and histopathologic features. So T4 is going to be positive much more than T3. LVI, again, much more than without LVI. High risk, of course, so the stage 2 with high risk features are going to be more likely to be positive than those with low risk. And then the deficient MMRs are going to be less likely to be ctDNA positive than those who are proficient. So none of that was really a surprise. It just correlated and with what we know from multiple prior observational arms. So stage 2 colon cancer, R0 resection, normal ECOG, they were all staged within 8 weeks. All of the patients got ctDNA testing at 4 weeks and 7 weeks post-op and were enrolled based on positivity in either of those. So if you were negative in 4 weeks but positive at week 7, you were also enrolled, and they were randomized 2-to-1. The two arms were, again, ctDNA guided. So if you were ctDNA positive, you got adjuvant chemo, but they didn't specify if you needed to give oxaliplatin or single agent 5-FU. That was up to the physician's choice. And then if you were ctDNA negative, you went into an observation arm. That is versus standard management. And standard management was adjuvant treatment decisions based on conventional clinical pathologic criteria. And again, that was physician's choice. Whether they gave treatment, didn't give treatment, whether they gave FOLFOX, CAPOX, or 5-FU. And again, they used the SAFE-seq, which was tumor-informed, and then followed them up. What is important to note, and what I think is the biggest, setback in this trial, is that it was standard management. It wasn't standard management or standard of care. It was clinician's choice. And that I'll highlight that again in future in the upcoming slides. So look again, updated 5-year relapse-free survival and overall survival, no difference between CT guided and standard management. So you could what this highlighted is that you could use a ctDNA approach and not sacrifice efficacy. And then looking at this subgroup, these two different risk subgroups. So DMMR being a lower risk subgroup, and T4N0, which is arguably the highest risk subgroup. Patients who were T4 and had ctDNA positive and used the ctDNA positive reports had really good overall survivals of a 5-year relapse-free survival of 81% versus 70%, and that difference was not statistically significant. And in fact, it seemed, according to the way these lines split, it almost looks like the standard group did worse than the ctDNA guided group, though there was no difference. But it's really important to notice that the standard group, only 10% of this highest risk group got oxaliplatin, which is not standard of care in the United States. And only 70% of these patients got chemotherapy at all. So the majority of these standard group, in my opinion, were treated with substandard adjuvant chemotherapy. And interestingly, even in the ctDNA guided group, they did receive more oxaliplatin, but still only 16% of them received oxaliplatin. And then in this deficient MMR group, the standard group, 11% of them received adjuvant chemotherapy, which is not standard of care. There's no data to really suggest that there's benefit to giving stage 2 MMR deficient colon cancer chemotherapy, and then only 7.4% of them got oxali, which is, when you think of DMMR colon cancers, which are relatively resistant to 5FU chemotherapy, where the benefit of oxaliplatin is even more pronounced, they were treated with 5FU alone. And similarly, even in the ctDNA guided group, only 6.8% of them got oxaliplatin. And then when you look at I think this was a really great assessment that they did. They looked at end of treatment ctDNA clearance and relapse-free survival. So in those patients who got oxaliplatin, not surprisingly, and this kind of was shown in the Mosaic trial, the addition of oxaliplatin improves outcomes. And so ctDNA clearance was higher, 92% versus 78%, with the addition of oxaliplatin. And then if you had ctDNA clearance, those patients did really well. Only 8.6% of them recurred, and versus 80% recurred if they were ctDNA positive at the end of the trial. So what this shows is that adjuvant chemotherapy does help this patient population, particularly if they have ctDNA clearance. I will also note that the absolute number, only 8.6 recurrence in ctDNA cleared patients, is higher than in most of the observational arms. So the people in this group, in this study, just did well. So is this practice changing? No. The short answer is no. And I think the biggest reason is because of the standard of care versus clinician's choice. They really were not treated per standard of care. Only 50% of the highest clinical risk patients received adjuvant chemotherapy, period, in this standard management group. Only 24% of poorly differentiated tumors, so grade 3 tumors, received adjuvant chemotherapy, and most patients did not receive oxaliplatin. Whereas you could argue that standard of care, the majority of these patients should have received oxaliplatin. So what does this trial tell us? It does, for low risk patients who are ctDNA negative, they do really well, regardless of whether they're in standard or in this high risk group. The ctDNA status remains the highest prognostic factor after an R0 resection, and that the conversion of ctDNA from positive to negative confers improved prognosis, and the majority of patients did convert. signifying that adjuvant chemotherapy was effective. So we're still not using it as a decision tool. There are many trials underway to assess, to explore this further. Dynamic 3 is the same as Dynamic 2, but they are using the stage 3 population and a de-escalation and an escalation method. So if you are, again, it's the standard of care, which is not standard of care. It's clinician's choice versus ctDNA informed, and there are actually a number of groups that they're comparing, de-escalating and escalating. Ways that they escalated adjuvant chemotherapy is by treating some of them with FOLFIRINOX, and ways that they de-escalated adjuvant chemotherapy is they went to 5FU versus FOLFOX. That study is close to accrual, and we're awaiting results. And then there's the Vega and the Altair trial, which are the two interventional arms in the Circulate Japan. Vega is in ctDNA negative patients, and so high risk stage 2 and low risk stage 3, where they're going to be stratified to observation, or randomized rather to observation versus adjuvant chemotherapy. Then there's the Altair, which is ctDNA positive, stage 2 or stage 3, so the highest risk patients. All of them are getting adjuvant chemotherapy as per standard of care, and then they're being randomized to receive either placebo or 6 months of Lonsurf. I question the feasibility of this group. I'm not sure Lonsurf is going to add much, but I guess that remains to be seen. Then there's the Circulate North America, which is stage 3 and high-risk stage 2, and they are being randomized if they're ctDNA negative to observation versus FOLFOX, and if they're ctDNA positive, FOLFOX versus FOLFOXIRI. That's currently still enrolling. The TRACK Part C is similar in UK, and then the LSP Amore, which is a trial we had here. It is being sponsored by BioNTech, and this trial just recently closed to accrual. It was they identified the patients who are stage 2 or stage 3 and ctDNA positive, so highest risk patients, after standard of care adjuvant chemotherapy, and then upon completion of that adjuvant chemotherapy, whether it be CAPOX or FOLFOX, 3 months or 6 months, they would be randomized to either observation or 1 year of a individualized mRNA vaccine based on their tumor. Unfortunately, none of the patients that were ctDNA positive here were randomized to the intervention arm, which is to receive the mRNA vaccine, but we have 3 patients who are being followed on observation. Any questions on ctDNA? All right. Now I'm going to talk about neoadjuvant chemotherapy, because I think I get a lot of questions about this from the inpatient side. So there are 3 randomized trials: Foxtrot, Neocol, and Prodige. Foxtrot is the biggest trial. It is the only randomized phase 3 trial, and of the 3, this is the only positive trial. They took high risk T3, T4, N0, N2. They defined them as high risk based on imaging, so preoperative imaging, which is well known to be a little bit to not be accurate, frankly. And then they were randomized 2-to-1 to FOLFOX for 3 cycles, so 6 weeks, then surgery, then the remaining of 12 cycles of FOLFOX, so 9 cycles, versus standard surgery followed by adjuvant chemotherapy with 12 cycles of FOLFOX. And their primary objective was relapse-free survival, or relapse rate. RR is relapse rate in this at 2 years. And their secondary objectives were R0 rate, perioperative safety, downstaging, tumor regression. So this was, again, a phase 3 trial of neoadjuvant chemotherapy versus standard adjuvant chemotherapy. And what they found was that there was no difference in perioperative morbidity or length of stay, and in fact a trend toward fewer perioperative complications in the neoadjuvant treatment arm. There was significant downstaging in those who received neoadjuvant chemotherapy. No real surprise there. At least 60% of those patients had mild regression, and 4% with CR. Which makes you wonder how many of these patients were actually overstaged on imaging. Fewer incomplete resections. So we're talking about more R0 resections. So there were only 10% in only 5% in those patients who got neoadjuvant chemotherapy versus 10% who did not receive neoadjuvant chemotherapy. And then when they looked at the subgroup analysis, that benefit was most prominent in left-sided and T4. So left-sided being the group of colon cancer that is more sensitive to chemotherapy, and T4 being a higher risk group. And then in terms of their primary outcome of relapse rate at 2 years, it was 16.9% if you got neoadjuvant chemotherapy versus 21%, and that was statistically significant. But there was no difference in colorectal cancer specific mortality. And then, they did include deficient MMR patients, and not surprisingly, there was a lower rate of tumor regression with neoadjuvant chemo compared to if they had proficient MMR. And we know that if you're deficient MMR, do those patients respond to chemotherapy? Yes, they can, but compared to MMR, they tend to have less robust responses to chemotherapy, but more robust responses to immunotherapy. And they had a lower rate of recurrence, which is probably just because they're DMMR, not because of the intervention. And then NeoCall was presented just as an abstract, CAPOX versus FOLFOX for 2 months, then surgery, then adjuvant chemotherapy versus standard. This was a negative study. There was no difference in 2-year disease-free survival or overall survival. They had fewer perioperative complications, but I'm not sure what that significance is. And then the PRODIGE 22, and then similarly, they had, not surprising, they got neoadjuvant chemo, so they had a higher tumor regression grade, but there was no difference in 3-year overall survival or disease-free survival. So the takeaway is that neoadjuvant chemotherapy is absolutely not standard of care in colon cancer. But it is considered in certain scenarios, especially in T4, T4B. So if you have a sigmoid tumor invading into the bladder or into the vagina, then you should actually consider neoadjuvant chemotherapy. And then the other population I've given it is in select patients who require delay in surgery for medical reasons. In 3 patients, the reason I did neoadjuvant chemotherapy is because they presented with a massive or a submassive PE at the same time that they were diagnosed with colon cancer, and they were not surgical candidates in the initial 3 months of anticoagulation. So I gave them chemo for 3 months to bridge them, and then they went to the OR. But otherwise, I certainly do not do this as a standard of care. Again, like 66%, if you look at Foxtrot, had mild regression. So, you could, in the patients who don't respond to neoadjuvant chemotherapy, you could, put them at higher risk for obstruction and things like that if you delay their surgery. And then neo/adjuvant therapy in MSI high patients. There is increasing data in this topic. So in general, defective MMR, loss of MLH1, MSH2, MSH6, PMS2, about 15% sporadic, 90% are MLH1 loss either through hypermethylation or another reason, BRAF mutation, clinical correlate. They're usually right-sided. They're more female than male, early stage with better prognosis. When histologically, they look worse under the microscope. So they look poorly differentiated. They will have signet ring or medullary features, which in proficient MMR is higher risk, but in deficient MMR is irrelevant. And they sometimes pathologists will comment on lymphocyte infiltration. So defective MMR is predictive and prognostic. And then, we know that it's predictive in that they're relatively resistant to 5-FU alone, and in that they demonstrate superiority to PD-L1 therapy over standard chemotherapy in the first line. So it's prognostic, whether you give them chemo or not, they do better, and it's predictive. There's no benefit for adjuvant chemotherapy in the stage 2 population, but in the stage 3 population, they derive benefit and along a similar order of magnitude compared with the MSSS population in the cohort of patients in the MOSAIC trial that had deficient MMR. And so if you have a patient with stage 3 MSI high colon cancer, you should be treating them with adjuvant chemotherapy. To date, there is nothing that has displaced, there's no data supporting anything other than adjuvant FOLFOX or CAPOX in MSI high stage 3 colon cancers. There are trials ongoing, but none of them have resulted demonstrating the benefit of immunotherapy in the adjuvant setting. One trial that we conducted here that has been closed for now, I think 3 years, is the phase 3 randomized controlled trial, ATOMIC, which is a cooperative group trial, to determine if the addition of atezolizumab to the standard of care, FOLFOX, would improve disease-free survival versus FOLFOX alone. And so patients in the atezo arm got 6 months of combined treatment, chemoimmunotherapy, and then they received 6 additional months of atezo alone versus standard of care, FOLFOX for 6 months and then surveillance. So we await those results. But then there is data now for neoadjuvant immunotherapy in MSI cancer. So it started with the NICHE study. This was a trial of 40 patients with stage 2, 3, both deficient MMR or proficient MMR colon cancer, given a single dose of IPI and 2 doses of Pembro, and then they had surgery within 6 weeks. All 20 of the MSI high patients had a major path response defined as less than 10% residual disease, and 60% of them had a path CR. And actually, 27% of proficient MMR had some response. There were toxicities. I mean, 15% of these patients had grade 3 to 4 treatment-related adverse event, and 10% had anastomotic leak, which is very, very high. I would say the rate of anastomotic leaks for colon cancer, not rectal cancer, is 1% or less. So that was very significant. They followed that up with the NICHE 2 trial, which enrolled 115 patients, all deficient MMR. 37 of them had Lynch, 76 had sporadic MMR, and 2 were unexplained. And they treated them with Nivo for 2 doses and IPI for 1 dose. So Nivo 3 and IPI 1 on day 1, and then 1 more dose of Nivo on day 15, and then surgery within 6 weeks of study enrollment. So if you enroll in the study and then get Nivo IPI on day 1 and Nivo on day 15, that means you're going to surgery within like 3 or 4 weeks of receiving your last dose of immunotherapy. They found similar robust responses, major PAP CR in 95% of patients, major PR in 95%, and then PAP CR in 68%. 4 patients had partial responses, which is 18 to 35% residual disease, and only 1 patient had what they considered no response, with 60% of residual viable tumor. BRAF mutated patients had lower PAP CR rates than BRAF wild type, and PAP CRs were higher in RAS mutant versus RAS wild type. The median follow-up was 26 months, and none of those patients had recurrence. But there were treatment-related adverse events. In 2 patients, myositis delayed the surgery beyond 6 weeks. And there were, even though 63% of patients had immune-related AEs, most of them were grade 1, grade 2, but 4% had grade 3 to 4. So rash, asymptomatic increase in amylase, the myositis, hepatitis, hyponatremia. But again, this high 3% anastomotic leak and 10% surgery-related grade 3 events. So that is not insignificant. And look at, have you seen a nicer waterfall plot where like everybody responds and responds beautifully? So you know, how often do we give neoadjuvant immunotherapy? Most people don't need it, frankly, right? I mean, this is a population that if you do nothing, their survival is amazing. So why introduce increased risk in those patients? However, if you have someone who has a T4 cancer, who is MMR, or like a big bulky cancer where there is concern about R0 resection, then absolutely give. I have done that. I'm going to say I've done that now 3 times. One was a transverse colon mass that was invading into the serosal surface of the duodenum, and so he would have needed a Whipple. And so I asked them to, I was called from the OR. I told them to stop, just do a diverting-ostomy, and I gave him Nevo-Ipi. I actually gave it to him for 2 months, and then he went to the OR and he had a PAT CR. It was actually before the Niche 2 trial was published, and that was just published in June. Say it again?
Was it MMR revision or revision?
I'm sorry, I still didn't hear you.
What was the MMR status of that patient?
He was MSI high.
Okay.
So again, I'm just talking in this scenario. I'm just talking about MSI high patients. So I think but if you have a standard patient with with a MMR high, microsatellite unstable patient who has resectable disease, then I would not give them neoadjuvant immunotherapy. I mean, you're exposing them to risk, and I'm not sure if though this trial definitely shows high PAF CR rates, I'm not sure that that's going to translate into an overall survival benefit because these people do so well anyway. Again, with the exception is if they have, if it looks like they have lymph nodes that are positive, if it looks like they're invading into an adjacent structure, that's a different story. You might benefit from them. In that situation, the benefits, could certainly outweigh the risks. And I think they are planning a trial to assess for, similar to the dostarlimab trial in rectal cancer, of considering Nevo-Ipi as a definitive treatment. But there are going to be problems with that trial. Like, how are you going to follow up for a response? Yes. A lot of people had CRs, but what about if you look at the Niche 2 trial, only 68% of those patients had PAT CRs. So what about the other patients? How are you going to assess them? Are you going to do colonoscopies? Most of MMR tumors are right-sided, so you're not going to be able to access that with a flex sig like you can in rectal cancer for the dostarlimab trial. You're going to have to do a full colonoscopy. And what are you going to what is the pace of colonoscopy every 3 months to look for local recurrence? So I'm not sure it's going to displace surgery unless in very specific scenarios. And that's it. And we are over. So any questions?
Thank you.
Hi, Rimini, this is Ruan. Thanks for the talk. I just had a kind of practical question on that clinical vignette patient. So when he has, someone with like baseline neuropathy, it's not yet painful, but you're going to start them on oxaliplatin. I know there's data that for painful neuropathy and SSRI can help. Do you preemptively, is there any data for like prophylaxis to kind of prevent it from coming on, or do you just wait and see?
No, so this goes to one thing that I did mean to talk about, which is how do I use ctDNA positivity? So the way that I use ctDNA is that I don't use it to decide whether or not I'm going to give someone adjuvant chemotherapy. I tend to use Signatera, which is tissue informed, and so I often don't have the results of that back when I'm starting adjuvant chemotherapy. When you start adjuvant chemo, the best window of initiation is really between 4 to 8 weeks post-op, and you don't want to wait, especially more than 10 weeks. There's data showing decreased responses if you wait more than 10 weeks to start adjuvant chemotherapy. So the way I use it is I use it in this. So the reason I checked it in this guy is because I was worried about his tolerance to adjuvant chemotherapy because he had this pre-existing neuropathy. And so I will often check it on older patients, on frail patients, where if I anticipate there might be a future issue with chemotherapy, if they are ctDNA negative, I am less likely to push them in the setting of adverse events or poor tolerance, rather than using it as a decision maker of, do I give them neoadjuvant chemotherapy or do I not? If the ctDNA comes back negative and they're tolerating it well, I still give it to them. But this guy, I'm giving him oxaliplatin, but I'm not sure how long he's going to tolerate it because of his pre-existing neuropathy. So I'm dose adjusting it to 70 milligrams per meter squared. You can usually give 4 to 6 cycles of oxaliplatin without really worsening their baseline neuropathy. And so what I discussed with him at our initial meeting was that I did want to give him oxali, but I was only going to give him 6 cycles, and also low threshold to stop if he has worsening, symptoms. And so I don't start by giving. So the SSRIs, really Cymbalta is the only one that has data behind it for chemotherapy associated neuropathy. I don't start Cymbalta. It's only for the pain of neuropathy. Most people don't have pain from oxaliplatin. Most people have symptoms from the lack of sensation. So they'll be like dropping things. They'll have balance issues because they are not able to, it's more the sensory deficit than the addition of pain. And so I don't find that it's that helpful. And even when I don't think, I would say it only works like half the time or less. So I don't give prophylactic Cymbalta.
Right. Thank you.
But I do dose reduce, and then I have a low threshold to further dose reduce or stop. Because even after you stop it, right, it can get worse for 3 months, and then you've already given it. You can't like unring that bell.
Right.
So he's ctDNA positive. I'm going to really try to give him at least 6 cycles of oxaliplatin. Whereas if he was ctDNA negative, I might not push as much. Anyway, anything else? All right. And so I think our next lecture is like June 16th or something, and that'll be metastatic colon cancer. All right. Have a good day.
Thank
Thanks.
you.
Bye.